Well, good morning. So I've been, I think I've given a presentation at this meeting every year except for COVID for the past 25 years or more. And it's always been fantastic to interact with families and with people who are really interested in their well-being. It's very special. But it's especially special this year because, as Jerry said, I trained here. And so I don't think they could have found a better chair than Jerry. I mean, as thoughtful as his presentation was, this is how he is in all aspects of his life. So they're very lucky to have him. But the second reason is because one of the most thoughtful physicians I've ever worked with, certainly when I was a resident, is here, Linda Gray. So I hadn't seen her in 30 years. But importantly, this is the first time I actually, my son attends one of my presentations. So there's Jamie right there at the risk of embarrassing him. So, okay. So I want you to know how we think. Like Jerry said, we want you to know what we're thinking when we're giving you advice. And I'll start with defining Syringomyelia. I'll give you stuff that you already know. But then as we make decisions, I want you to look at the breadth of information that we're really mulling in our head as we're trying to come up with a diagnosis and with treatment plan. So Syringomyelia is from Syrinx in Greek and myelos. That means a pipe in the marrow or the spine. It's just a fluid collection inside the spinal cord. Before we can figure out when to worry and what to do, we have to understand the anatomy of a syrinx. We have to know what a syrinx damages and why it damages it, and what we think is going to happen in 2 months if we don't do anything. We want to know what other associated brain and spine anomalies are. If someone is symptomatic with a syrinx, the symptoms could be coming from the Chiari. We want to know the causes of these neurological symptoms. And then what makes certain syrinxes high risk and certain syrinxes low risk. Now, as Jerry alluded, we don't have a lot of information in literature, so this would be a mix of our own experience and whatever literature is available. So, a syrinx is a fluid-filled cavity. It's known by many names. Currently, everybody uses Syringomyelia, but in the past we've used hydromyelia, syringohydromyelia, spinal cord cyst, and if it extends all the way up to the brainstem, syringobulbia. So if you see these in the literature, they're really equivalent terms. Now I'm going to tell you a little bit about the anatomy, how we think syrinxes damage. So a syrinx, this is a cross-section of the spinal cord. So if you cut right there and you splay it out, that's what you see. And when you put a syrinx in there, it's central in the spinal cord. It's damaging these structures that are in the middle. Okay, so what does that mean to us? Well, look at this pathway, for example. This is the motor pathway. So the motor pathway is laminated. So the fibers at the very medial aspect are the arm fibers, and then thoracic, then lumbar, then sacral. Which means if you have a cervical syrinx, the first thing that gets damaged are the arms, and the first thing in the arms is the hands. Whereas if the syrinx is in the thoracic region, the first thing that gets damaged is the chest muscles. So if you weaken the chest muscle, you get scoliosis, for example, or you can have breathing problems. So when we see a syrinx that is causing motor problems with the arms but not the legs, that's very normal to us. It may not be logical to people who don't know the anatomy, so it's important to know it. Now, what about sensation? Well, imagine you have a syrinx in the chest, in the thoracic region here. What happens if you damage the medial aspects of these laminated structures? This is the sensory pathway here. It's laminated the same way. Well, you lose sensation in the chest, but you don't lose sensation in the arms or the legs. Which means if you go to a doctor's office and they test your sensation in the hands and the feet and they tell you you're normal, they haven't done a full job. You have to also look at the chest. So that's called dissociated sensory loss. So this is called the central cord syndrome, which is a typical manifestation of syringomyelia, and this is dissociated sensory loss. Okay? All right. So what if the syrinx, instead of being in the spinal cord, is up in the brainstem? Well, what happens then is you develop brainstem signs and symptoms, the most common of which is lower cranial nerve dysfunction, such as oropharyngeal dysfunction, inability to swallow, inability to breathe. You get apnea, central apnea. You've seen people around you going through these. Well, that's because the upper cervical spine and especially the brainstem control these areas, these functions. Chronic pain. When you damage nerves, they develop seizure-like activity, and they start to cause pain. And the pain is not noxious pain. It's not like when someone cuts you with a knife, for example. It's more deep. It's coming from the spinal cord itself. Opioids don't help. There are medicines that might help a little bit, but these are very difficult pain syndromes to take care of, which means that the best way to take care of these is to prevent them. If you start having pain from syringomyelia, you're already a little bit too late, because once the pain becomes chronic, it's going to become very intractable to medication and to other therapies. And the final one is scoliosis. If you damage the muscles of the chest won't be held upright. It starts to curve. And this is what you see here. Okay? So this is how the anatomy relates to the functional physiology of the system. So based on this, let's go through how to diagnose syringomyelia. As you all know, spinal MRI is really the most important aspect of it. It's the standard of care. As Jerry said, brain and spine MRI, full brain and spine MRI is essential in our opinions, because you want to not just look at the syrinx, but you want to look at other associated anomalies. A cine MRI is still controversial. I used to do a lot of research in this area, and then I stopped because I just couldn't correlate it very easily with symptomatic states. And then myelography is a thing of the past. We use it only occasionally in post-traumatic syringomyelia or acronyditis. All right. So when do you intervene? Well, we definitely, most of us, treat a symptomatic or large syrinx, especially one that is enlarging. So that's a large syrinx in the upper cervical spine. I don't know a lot of neurosurgeons who don't treat this, with one exception. I have several patients. I have a lady, for example, who's in her 70s, and she presented with this and has some subjective symptoms. I can imagine this could have been there for 40 years. So I didn't treat her. I follow her with yearly imaging, and I follow her neurological exam very closely, because the likelihood to develop symptoms at that age is very low. So these are the nuances that we're thinking about every time we see a patient. When do you not treat? Well, the opposite. If the syrinx is small and if it's asymptomatic. So there's a syrinx here. It's very small. It's actually very common in kids to have this kind of syrinx called ventriculus terminale, which means just dilatation of the central canal down here. And the most extreme form of this is what has been mentioned several times during this conference, which is the dilated central canal or slit-like syrinx cavities, which, I mean, we've been taught how to manage these by Rick Batzdorf. And those are inoperable, and I haven't seen one progress over time. So, most importantly though, once you decide to treat a syrinx, you have to treat the primary etiology. Syringomyelia is a secondary problem. It's not a primary problem. Even though we have idiopathic syringomyelia, in the opinion of many, it's a syrinx where the primary cause has not yet been identified. We don't have technology good enough to say why this happened. Okay. So what are these etiologies? Chiari 1, most important one because that's most common. The diagnosis is made by MRI, and the treatment is posterior fossa decompression. But there are complicating factors. Every time you see a Chiari and Syrinx, you don't just do a posterior fossa decompression. There could be secondary problems that arise here. One is you could have increased intracranial pressure, such as pseudotumor cerebri, or even hydrocephalus, like in this case. You can have craniocervical instability. Look at the angle of the craniocervical junction here, how it's compressing the brainstem. If we just do, this patient has already had a fusion, as you can see here, but if we had just done a posterior fossa decompression, there is literature, especially from Dr. Meneses' group, that says that you're going to make the person worse if you just decompress without a fusion. So there are really complicated factors to take into consideration before you treat a Chiari syringomyelia patient. Okay, spina bifida, myelomeningocele, or Chiari 2. This is what the myelomeningocele looks like. These are birth defects. In this case, you have hydrocephalus and you have a syrinx. This is the Chiari 2 malformation. And again, as Jerry suggested, is when we started our practices, we used to do Chiari 2 decompressions all the time. I haven't done one in 15, maybe 20 years. That's because what we realized is that the primary problem is not the posterior fossa. Primary problem is the hydrocephalus. And once we recognize that there are some patients who fail their shunts but don't dilate the ventricles, but still they have shunt malfunction, then we started revising these shunts, and we haven't had to do posterior fossa decompressions. And what people think is that the Chiari symptoms are really a reflection of brainstem damage at birth because it's been stretched for so long. And then when you have a shunt malfunction, or you have the flu, or you have any kind of stress to the system, that can push it over the edge and give you Chiari symptoms. You start having big gag reflex, you start having apnea, you start having swallowing disorders. The bottom line is we don't operate on Chiari 2s anymore. However, syringomyelia does happen. And the way to look at it really is syringomyelia is hydrocephalus but in the spine. So you can imagine what can cause this is a shunt malfunction, or if this area that we repaired at birth tethers, it gets scarred down, it causes obstructive processes, and syringomyelia can form. The teaching is you always check the shunt first. So whenever we have a child with this and he's symptomatic, we check the shunt first, and if that doesn't do anything, then we go to the tether cord. This is a spina bifida patient, just to show you how the syrinxes can be very odd and disconnected. So this particular patient has a syrinx in the cervical spine and another one in the lumbar spine. But if you look here, this is endoscopic view. There's no obstruction between the two. They're in communication. But the different parts of the spinal cord dilated because different compliance. In this case, all that child needed is a shunt revision, a VP shunt revision. Congenital tether cord is when you're born with anomalies of the spinal cord, but the skin is closed. It's not an open defect, it's a closed defect. Oftentimes, you can tell by looking at cutaneous anomalies in the back, such as a dimple, a hair tuft, hemangioma, and others. And that indicates there's a problem in the spinal cord. This, for example, is called the lipomyelomeningocele, where there's a fatty mass under the skin that attaches to the spinal cord and tethers it. Well, this tethering here can cause syringomyelia. In this patient, there was a thick phylum that was tethering the spinal cord, and you can see the syrinx here in the distal aspect of the cord. These, again, are treated by untethering the patient, by treating the primary malformation. Now, sometimes if the syrinx is really big, you could drain it at the same time, but the primary repair is the most important part of this. Now, traumatic syringomyelia is a bit difficult. The reason being is that there are at least two possibilities. One possibility is that it caused scar tissue around the spinal cord, arachnoiditis, which then creates obstructive processes to cause syringomyelia. And those are treated, as I will mention in the next slide, by taking down some of the scar tissue. The success rate is not nearly as high as when you decompress a Chiari or you treat a spina bifida occulta patient, tethered cord, but there is a success rate according to some. The second reason is that when you have a spinal cord injury, you can have a hemorrhage inside the spinal cord, a contusion, which then atrophies and forms a cavity. Unlike true syringomyelia, this cavity is not under pressure. It doesn't need to be treated, and it doesn't enlarge over time. Okay, so this is a complicated. There's a lot of research in this area, but it's important to keep in mind that there's more than one etiology. Oops, sorry. Yeah, and arachnoiditis is just this scarring around the spinal cord, which can be caused by trauma, but can also be caused by infection, by hemorrhage, etc. And those are difficult to treat. So, spinal cord tumors can happen. This here is a tumor in the spinal cord that caused a syrinx to form above it. And obviously the treatment here is to take out the tumor, and the syrinx usually resolves. And that's the reason why we get MRIs with and without contrast when we look for causes for syringomyelia, is to look for these types of anomalies, tumor, arachnoiditis. And finally, the part of it that's most difficult is idiopathic, meaning there's no cause that's been identified. These are difficult to treat because we don't like to do syrinx shunts because they cause a lot of long-term morbidity and their success rate is not very high. The bottom line is that we follow them very closely. If they seem to progress and cause symptoms, then we have to treat them. The traditional treatment is syrinx shunts. The alternative nowadays is to consider something called the Chiari zero, which is a whole different lecture. But that means that the posterior fossa could have abnormalities in it, but you're not seeing them on MRI. There's not a true Chiari 1 malformation. But we'll leave that to another time. So what is the prognosis of all these? Chiari decompression for syringomyelia has excellent prognosis, 80 to 90% success rate, especially in children, less so in adults. Treatment of syringomyelia from spina bifida is excellent based on adequate shunting and untethering the spinal cord. Arachnoiditis, very difficult because oftentimes the arachnoiditis is very diffuse in the spine. There could be a focal abnormality, but oftentimes it's diffuse. It's very difficult to take down, and even if you do it, it could reaccumulate, scar tissue reforms. So these are difficult patients to treat. Traumatic, very similar to arachnoiditis, and tumor. And tumors, if it's a benign tumor that has an excellent prognosis, of course it's a malignant tumor. The prognosis is related to the tumor, not to the syrinx. Now, when do we really want to operate? Definitely, if the syrinx goes up into the brainstem. That is an operative indication because damaging the brainstem can be life-threatening. If the syrinx is enlarging, you're following it up and then it's doubling in size, that's a problem that needs treatment. When it's symptomatic, especially if there are brainstem symptoms. In three-year-olds, for example, and infants and toddlers, the most common symptom is oropharyngeal dysfunction, swallowing, apnea, etc. And if there's progressive sensory motor symptoms. And of course, we would operate if the primary disorder, the Chiari, the tumor, or tether cord are symptomatic. So when do we not intervene surgically? We mentioned dilated central canal. I don't know anybody who operates on these. If the syrinx is small and asymptomatic and doesn't have a major cause that is symptomatic, we don't operate on these. And age, as I mentioned before, the older you get, if you've had a chronic syrinx, I don't, most of us feel that operating isn't going to help the chronic symptoms. But that can be controversial, and that's case-by-case basis. So, Syringomyelia occurs secondary to other disorders. The goal is to treat the primary disorder. Shunting the syrinx is done only as a last resort. There are clinical algorithms for care based on etiology. I won't bore you with these. And I'd like to thank you.